Welcome to all the participants for today's webinar on interesting topic related to COVID-19. I am Arun Vijala, Managing Director for Converge Biotech. We are based out at Hyderabad and we are into manufacturing and marketing critical care and cardiometabolic products and marketing pan-India. The values we breathe in are quality, affordability, and accessibility. We keep academic initiatives as one of our priority, and in past we have been participated in several professional academics events as well. Today, we have with us eminent speakers who will share insights into the global pandemic challenge, COVID-19. It is my privilege to introduce our first speaker of the day, Dr. Kapil Zirpe, an MD chest and holding FICCM and FCCCM. Dr. Zirpe is Head Department of Neurocritical Care, Ruby Hall Clinic, Pune. Dr. Zirpe is a past president of ISCCM and is also organizing secretary of Best of Results, Pune. He has to his credit several research publications and academic books. Our second speaker for the day is Dr. Shubhal Dixit, MD Medicine and holding IDCCM, FICCM, FCCCM, and FICP. Dr. Dixit is Director Critical Care, Sanjeevani and MGM Hospital, Pune.
Hello.
Dr. Dixit is an immediate past and immediate past ICCCM. He has several books and research publications to his credit. Now I would request Dr. Kapil Zirpe to start with our first presentation on infection control and management of COVID 2019. And request Dr. Dixit sir to moderate today's webinar and take questions from the participants. Thank you.
Yeah. So just before Dr. Zirpe starts, I would like to make certain house announcements. All those who are listeners, please keep their mics on mute. Please type the questions in the question answer box. At the end of both the talks, I will be taking the questions and either myself or Dr. Zirpe will be answering to those questions. So now I request Dr. Zirpe to please start his presentation.
Okay, Arun and Shubhal for the very kind introduction. And sorry, my video is not on, but I hope most of the you people are knowing me. So today's topic is infection control and management of COVID. Now, I don't need to tell you what is a COVID. Up till now, everybody is quite aware about the scarcity of the disease and the speed with which it is going around. So I'm not going to speak much about what is the pathophysiology and what will be the clinical features. We'll try to see how we can prevent it with the very basic steps if we follow in our practice in day-to-day life. Like if you go through the natural history, of the COVID or any illness, there has to be the pathogen, there has to be the reservoir, there has to be the portal of exit for that reservoir, there has to be the mode of transmission, there has to be the portal of entry, and then there has to be the susceptible pathogen. And this cycle go on. Now, if you see for the COVID, what is the pathogen? It's a COVID-19 is a pathogen. Reservoir unknown at present. Somebody says it is a bat, somebody says it is a seafood, somebody says something else. So nobody is very clear about the reservoir. Portal of exit, most of us now convinced that this is likely to be airway or saliva. Transmission, again the spill hole is very likely to be. Portal of entry, airways, might be there are now fecal-oral route is also established, and there are so many other things. Susceptible host, any individual exposed to the virus, whether it is healthy or whether it is a comorbid condition. Comorbid conditions have a more prone for this video. And if you go further, coming to the ICUs and the hospitals, the reservoirs might be now these surfaces where commonly surfaces like telephone, laptops, and doorknobs, handles, ventilator systems, and might be it is a respiratory droplet or mucous membrane contact while doing the suction, while doing the nebulization, while doing the aerosol procedure. These might be the now transmission into the healthcare workers as well as the around. So this virus is not SARS. This virus is not Middle East respiratory virus. This is a COVID-19, which is a SARS-2. So if you see the different studies regarding the bronchoalveolar lavage, you can see respiratory samples, yes, 50% sample we can get. Mother to child intrauterine assessment, there is no evidence at present. Saliva, Yes, 91% of the time you may get feces. 12.3% documentary evidence regarding the tears, semen, vaginal fluid, or other body fluids viral. There is no evidence at present. Okay, so come back to the very basics. What is the transmission-based precautions? If you see the any suspected or confirmed case of the COVID, non-airway generated procedures, you have to take the standard plus contact plus droplet precaution. And the moment you go for the airway generated procedures like nebulization, open suctioning, or coughing, or intubation, extubation, your droplet precautions will be taken over by the airway precaution. That is what the very basics of the COVID management. COVID is a still droplet precautions. It has airborne nature in presence of the airway generator procedures or symptomatic patients if it is coughing. This was one of the slide I came across from the 2001. If you see the resistance pattern, this particularly COVID virus is a lipid-based virus, so it is less resistance as compared to the other bacteria. And if you go through the which are the agents which we can use for the surface disinfection or cleaning is the ethanol 70%. It is quite reliable. Sodium hypochlorite 0.1 to 0.5%. It is reliable. Povidone iodine, it may be. Glutathione, it may be, but rest of the these agents are not effective in disinfecting this particular virus. Now, there is no replacement for the hand hygiene. You have to do the hand washing. Everywhere we are talking about hand washing, but we have to stress on how to wash hands. You have to wash the hands very thoroughly. You have to wash hands with the proper steps, at least 5 steps, 7 steps. One should know that it has to be the thorough washing has to be done. It is not that just put your hand below the tap water and you are safe. So coming back to the precautions, if you understand what type of the infection you are dealing, you have to wear that type of the protection. Like for example, if you are coming across the COVID positive droplet infection, contact precaution has to be taken. If you are coming across the non-airway aerosol generation procedure, the simple surgical mask will be fine. If you are coming across the airborne, that means the aerosol generated procedures, I repeatedly telling, then N95. Regarding the surgical mask, it fairly loosely fitting. It is not the protection against the aerosol procedure. These are single-use masks. If they are wet or if they get please just remove them. If they damage, just remove them. So they are for the regular healthcare workers who are working in your ICUs. On the other hand, these are the N95 mask or 95, 99, F1, F2, F3. These are all these masks are the filtered masks. These are the masks which prevent from you from the entering the virus into your respiratory tract. These are the prevention against the aerosol masks. They are very tightly fitting masks. They are very uncomfortable. One needs to do the fitting test before using all these things. So one need to know what type of the mask they are using, why they are using, and in what situation they are using the mask. Like for example, one should know how tightly it has to be there. There should not be the leak, or there should not be the leak. Then these masks are not effective. So coming back to one of the frequently asked questions, which N95 mask I should use, whether with the wall or non-wall. That's simple to understand. Even the wall mask there is the inside wall, or non-wall mask, there is a built within the fiber, so there is no visualized wall. These are the wall masks are bulkier and heavier as compared to the non-walls. They are light and weight. But the ease of breathing is with the wall. Comfort is more with the wall 95. For the lung disease is a wall 95. And for COVID, they said the non-wall mask will be sufficient because they are lighter. You go for the more prolonged 6 to 8 hours with this mask. And there's this is another very good comparison in between the different N95 or respirators like N95, 99, 100, FFP1, FFP2, and FFP3. You need to understand the word itself explains 95 means 95 protection from the bacteria and virus to enter, 99%, 100%. And these are the layer. But out of that, FFP1 are not meant for the COVID. The rest of the others are meant for the COVID. So to summarize, when to use the surgical mask and when to use the respirator. Surgical masks are for when you are coming across you are not dealing with the suspected or COVID positive patient, you are not going into the immediate vicinity. You are not going ahead with when there is a aerogel generation procedures are happening. And the moment you go for the aerogel generator procedures, the state where you will replace it with the N95 mask and you be in an N95 mask along with the rest of the PPE like gown, gloves, shoe cover, mask and goggles. One should remember, please do not use only N95 mask and enter into the aerogel generation procedures along with PPEs must. So what is PP? One should understand there are the different parts of the PP, but there are very basic principles, general principles of the PP. Hand hygiene has to be maintained before wearing and after removing the PP. The moment your PPs are damaged or there is a breach in continuity, please remove them. After the procedure is done, or if you are coming out of that aerogel procedure, remove PP and just dispose it properly. These are the very basic general principles about the PP. And then this chart, I say that just put chart in every ICU and just follow it. Who should use what? There is a lot of chaos. There is a lot of fear among the healthcare worker. Like for example, somebody is doing the triage at the entry point. Hand hygiene and the medical mask is absolute sufficient. If they are collecting the sample, then the hand hygiene, gown, water resistance gown, medical mask, respirator, goggles, and the this thing are. If you are coming across the suspected but non-aerosol procedure, everything will be there except the respirator. It will be replaced by your mask. And the moment you are going for the aerosol generation procedure, your medical mask will be get replaced by the respirator. So this is simple to understand. This is very easy. If we follow the basic droplet contact precautions along with the respirator in a particular situation, I'm sure everybody will be safe in coming months or year. So to summarize what the CDC guidelines, proper use of the PP, proper use means who should use the PP, who should use the what PP, that is more important. We are a resource limited country. We cannot have the luxury of having the mask and the gowns in a different situation. Eye protection is a must. Take precautions when performing the aerogen repeated procedures. We are repeatedly telling there is no compromise when you are doing the CPR or aerogen procedure without cover. Collecting the diagnostic respiratory specimen, yes, we have to use the full PP to go ahead with that. Regarding the visitor access and movement within the facility, it has to be the restrict. There are no visitors are allowed in that area of the isolation. You can do the video counseling. You can just ask them. You can do the telephonic consultation, explain them, and just keep crowd. Decentralization is the principle in the pandemic. Monitor and manage the ill exposed healthcare workers. This is a priority. If you do not have the backup, your whole system is going to collapse. And you have to how many staff work, what is the backup staff, you have to keep them in a different ways. Like you cannot keep the all to one building. Decentralize in a 50-50 patches and keep them in a different building. Keep them in a different wards and ICU. Keep them in a different duty schedule. So what will happen? We will be coming across whenever any worst situation, we will have the backup staff in place. Implement the environmental infection control, that is a must, and establish reporting within the healthcare facility and to with the public authorities time to time, which will help for the contact tracing and reducing the load on the society. To summarize with the very basics of the infection control, one need to understand what is droplet and what is airborne. One needs to understand which PP during the droplet and for the airborne. One needs to understand that we have to use them very clearly, but simultaneously we can't compromise with the use of the PP when there is an aerogen generation procedure. So in short, final 2 slides about the clinical management of the COVID. I don't need to go through that. Everybody knows now there are so many data is pouring, so many material is available, all WhatsApp group, mails and the communications are filled with this material. I will just try to summarize the very frequently asked questions. Which is a drug treatment, our ICMR guidelines mention the hydroxychloroquine and chloroquine. It has to be as per the mild, moderate, severe. If it is a mild, it is hydroxychloroquine with azithromycin for 5 days, 400 bolus, 200 milligram BD for 4 days, azithromycin 500 for 4 days. If it is a moderate to severe, then you can add the Tamiflu, that is oseltamivir. Along with that, you can try either lopinavir or ritonavir. There's a new antimalarial, the iotibactin is also available. This drug is very promising, though it's a trial is already out. This might be the promising in future, but we need to see what is happening with the results. We need to have the more data to confirm. But this drug seems to be positive along with or promising along with the available treatment. Regarding the other therapeutic options for the management, like antimicrobial therapy, it is very frequently asked question, which antibiotic I should prescribe? Again, if it is a confirmed case of the COVID-19 positive, you have to go ahead with which are the guidelines our ICMR set in. If he is associated with the bacterial infection like UTI or any other infection, you can choose your antimicrobial empirical as per your culture. You know your cultures. We cannot tell you which antibiotic you use. In after 4 or 5 days, if your procalcitonin are jumping, if your second infection is set, you can again use the empirical antibiotic in a combinations in a proper dose, right drugs with the right combination in the right person, and you can choose your antibiotic agent. And you have to choose when to de-escalate. In adult, again, the role of the steroid is very controversial. There are the few reports are saying that if you start in the mild cases, 1 milligram per kg might help to prevent into the moderate to severe. But again, this is not advisable to start the steroids because there are the adverse effects of the steroids. Already they are immunocompromised patients. They might land with the picking up the secondary infection. Routine use of the standard immunoglobulin, no, there is no evidence for that. Convalescent plasma, that is antibiotic-rich plasma. Yes, this seems to be very promising. Now, almost most of the centers are trying to use in a moderate to severe cases. Let's see how it results. The 5 patients data is already available. And there is insufficient evidence to reduce the recommendation use of any of the recombinant interferon or tocilizumab. But this is related with the cytokine storm. This is still, it is going on. What should be the ideal timing, whether it should be the early within 5 days or the after 7 days, in what doses, what are the complication, cost, availability. So you need to consider all this. There is no pinpoint answer for that. Use in every patient, use on the 3rd day, nothing like that. So this is still a debate is going on. Till then, we'll try to follow the advice of the ICMR. That's all. Thank you. This is my team who is managing the isolation ward in Ruby Hall at present. Thank you. Thank you very much. Shubhal?
Kapil. Now I'll be taking the next presentation on the role of vitamin C, and after that we will be going for the questions which have been come into the chat box, which have been come into the question answer box. Yeah. I request everybody to please type their questions into the question answer box, so that at the end of my presentations I will moderate it, and either myself or Dr. Zirpe will be very happy to take the questions in the question answer box. So I'll start off with my presentation now on the role of vitamin C. Again, I thank Arun for asking me to talk on this role of vitamin C. See, Kapil just discussed about the different medical management. This is also one of the therapies which have been considered used into different countries also. So let's see, in the history of vitamin C has gone right from 1920, where initially Dr. Alfred Hess considered to be used in patients of pneumonia or in patients of secondary pneumonia. And even when there was a large endemic which occurred in Sudan way back, where Professor Funk said that giving ascorbic acid definitely took after, and they cured multiple patients. So therefore, there's always a saying which we still remember, and we always see that having a glass of orange juice is much more better. So never leave the house without having a glass of orange juice. That itself says that vitamin C may be helpful and plays a very important role to maintain the immunity. The early history of vitamin C in common cold, right from 1970, there have been meta-analysis where they have published into this, where again placebo control versus vitamin C were taken into consideration, and these were responsible to look after and cure the vitamin C, and then looking after this, the common colds. Going further, the vitamin C basically is also called as ascorbic acid. It's a water-soluble vitamin. It's naturally available in the fruits, and oranges are one of the most important places where you can definitely get it. And more importantly, therefore, having oranges is much more better because of a natural source. What is the role of vitamin C? Vitamin C, if you really ask me, vitamin C has got immune enhancing as well as immunomodulating properties. It has got antioxidant properties as well as it also helps to maintain the epithelial integrity of the gut as well as the epithelial cells. And more importantly, it also promotes the NK activity and helps to differentiate between the CD4 cells and also the helper cells. And more importantly, most important is the antioxidant, anti-inflammatory properties, which help to suppress the downregulation of the upregulated cytokines, which plays a very important role. Now, the pharmacokinetics, if you really see of giving vitamin C orally as versus giving IV, you can see the square box. Once you give about 10 grams of vitamin C, the levels which are achieved are almost about 6 times more than what you can achieve it after giving it in the form of an oral form. Secondly, the oral forms, once you give, you can see here from the dotted graph here that you found that the levels are not so maintained at a particular stable that is above a particular level. And as a result of which vitamin C was considered to be given intravenously for anti-inflammatory or antioxidant or for the anti-cytokine properties. There was a Cochrane review where vitamin C supplementation helped and it for treatment of common cold. It reduced the symptoms of common cold, all these viral common colds, by 8% in adults and by about 14% in children. And here only about 1 to 2 grams were given into these, which was a very small dose. Now, if you consider a meta-analysis which was considered, and this came back in 2019, definitely using intravenous vitamin C was beneficial because it reduced the length of hospital stay by approximately about 18.2%. And there have been 3 analyses and 3 studies where they considered the length of mechanical ventilation, and there was a reduction in the length of mechanical ventilation when it was given in the intravenous form at high doses. And similarly, the effect of vitamin C on the length of ICU stay, here again they considered and compare it with oral as versus IV. There have been about 12 studies, right, which can be seen here, oral as well as intravenous, where vitamin C giving intravenously definitely reduced the ICU stay by about 7% to 8%. And therefore, there was a reduction in the length of stay as well as a reduction in the requirement of mechanical ventilation. I won't go into the details of COVID because Kapil has just covered about it. It's a pandemic and it's not caused by a novel coronavirus. But more important, from the respiratory point of view, this SARS-CoV virus is mainly attached to the ACE2 receptors. And through the ACE2 receptors, it mainly gains entry into the cells and mainly cause affection into the lungs. Similarly, at the same time, there is a dissociation between iron and ferrin, which leads to formation of porphyrin, and as a result of which the injury occurs, which is the one responsible for increase in the serum ferritin levels. But at the same time, if you really see, they also affect the lungs, and these affection of the lungs is mainly caused because of a large amount of a cytokine storm, which is caused by a capillary leak, which is then produced and produced as well as caused by means of these oxidative stress factors because of release of these interleukins as well as cytokines, mainly the interleukin 1, 6, 9, and 10. 6 plays a very important role, which we can measure it into the bloods, and therefore ARDS here is mainly characterized by severe hypoxemia, and certain patients can also land up into shock and multiple organ failure. Now, as I told you, the transmission also occurs of coronavirus by the use of porphyrins. They gain entry into the cells. And this is exactly the mechanism why we find that there is a low level of heme levels because of dissociation of iron from the hemoglobin. And as a result of which, there is a serum ferritin level which gets elevated, and the CRP level which gets elevated, which is very important as prognosticate markers, and you should regularly monitor it. And this ferritin is mainly used by the bodies to bind to the iron. The CT images, what you can see here, is mainly consolidations with bilateral involvement, mainly the posterior or the subpleural forms. There could also be air bronchograms, which can be seen here. Now, the current management has been covered by Kapil. I won't go into the details. Majority of the certain forms of treatment have been considered to be used on compassionate use. And more importantly is the macrophages, which play a very important, they mainly depend upon the ascorbic acid to as well as the glomerular nitric oxide. And these macrophages use ascorbic acid, that's vitamin C, to produce the nitric oxide. And these macrophages they generate, and this is called as an oxidative burst. And this oxidative burst is mainly responsible for killing up of the pathogens. And more interestingly, there is a negative feedback loop where the oxidative burst cells also kills the monocytes as well as the macrophages. And more importantly, the nitric oxide deficiencies in macrophages, they also form the insufficient ascorbic acid. And this is also one of the reasons why exactly the cytokine storm occurs. And as a result of which vitamin C was also considered to be used in the management high dose in the treatment of the cytokine storms. Now, high dose of intravenous vitamin C in COVID, this was also discussed and this was studied by Adnan. And the proposed mechanism was mainly, it is an antioxidant as well as an enzymatic cofactor for the physiological reactions. It also produces hormones. There is a collagen synthesis as well as an immune potentiation which is there. It also has got a spontaneously oxidizes both the intracellular as well as extracellularly form of the inactive form, which is the dehydroxyascorbic acid. And the deoxyhydroxyascorbic acid is unstable at physiological pH, and this is reduced back to vitamin C by the glutathione. And therefore, glutathione and vitamin C, they usually go hand in hand, and it may be irreversibly irreversibly hydrolyzed. Therefore, if you are giving a high dose of vitamin C, you should never give it with glutathione. And especially if you are giving glutathione, you must use a low dose of vitamin C, which is there. And hence, high dose of vitamin C generally assumption acts as a pro-antioxidant effect, and this is got a cell type manner which plays a very important role. And these mechanisms into ARDS, where if you can see here, these protects the loss of the epithelial as well as the endothelial barriers, and they enhance the neutrophil functions in a multidimensional way. And this also regulates the nuclear cellular responses to the stress hypoxia, and this by regulating the HMA1 alpha receptors. And more importantly, as I told you, it regulates the pro-inflammatory and the coagulation gene expression and orchestrates the immune system and circulating cytokine hemostasis in the pleiotropic ways. It means that there is a downregulation of the upregulated phenotypes at the same time, or the inflammatory markers, and there is an upregulation of the downregulated kind of hormones which are important. So therefore, it tries to establish a good amount of balance between the downregulated and the upregulated cytokines, or the inflammatory response is then balanced. And therefore, giving high dose has been clinically used for several decades. And in the recent expert panel said that giving a high dose of approximately 1.5 grams per kg body weight is safe and without any much amount of side effects. Sometimes steroids must be added to accentuate the potential anti-inflammatory actions. This paper was published in 2019. And as I told you, if you are giving a low dose, the low dose just means about 0.07 to 1.4 grams of body weight. And this is mainly used in other illnesses or in just upper respiratory flu-like symptoms, or in those patients of malignancy. It just has a more antioxidant support. And these can be given with glutathione. But if you really consider the anti-inflammatory as well as the oxidative purpose, what you consider to use as a pro-inflammatory dose, then you are supposed to use a high dose of 1.5 grams of per kg body weight. And usually this is not given with glutathione or other nutrients. And this plays a very important role in sepsis, and also by the Merrick study which was there. Because of the anti-inflammatory action and the oxidative stress, they could also take after where there was a reduction in the peripheral hypoxemia. And several sepsis resulted in the 40-fold increase in the GAP dehydrogenase expression. And more importantly, significantly, if you really see, the PRP activation mainly occurred that was of the nicotinase consumption followed by vitamin C. So in short, if you really see, there is a good amount of liberation of the anti-pro cytokine hormone. It produces a good amount of heat shock proteins which are then liberated. They also help to suppress the pro-inflammatory release or the cytokine storms which are released by the infective enzymes which have been released because of these infections. And therefore, a good amount of a rational or a balance is being taken between the upregulation of the cytokines and the downregulation of the cytokines. Indirectly, there is a pro-inflammatory as well as the inflammatory hyperactivation which occurs into the myeloid as well as lymphoid cells. There is a good amount of balance which is then achieved into this. So this is exactly the graph what I just discussed. This is available from the textbook. I won't go into the details for discussing into the details of it. And the role of intravenous also, as I told you, it is also helps to inhibit the nitric oxide activation and preventing the profuse nitric oxide production as well as the generation. And these nitric oxide scavengers losing the tight junctions of the endothelium, and they help to maintain the endothelial integrity, and the translocation of bacteria from the gut also does not occur. They also help to maintain the cellular integrity at the alveolar level, and therefore the lung injuries can also be reduced with the help of vitamin C. Now, the clinical evidences which was seen was the major trial which was published in JAMA. This trial was published by called as a SICLO study. This was again a multi-center study. These patients were randomized into a placebo versus vitamin C, and they used 50 milligrams of vitamin C every 6 hourly for about 4 to 5 days. This study was mainly taken into consideration the ARDS, and you can see here from the red line here as compared to the placebo. In the group where patients vitamin C were given, there was a 28-day lower mortality as compared to that of placebo. I know this was compared to a placebo because certain people will have doubts whether this was not a drug comparison. It was compared with the placebo, but more importantly, it had pro-inflammatory responses, antioxidant properties, and there was reduction in the 28-day mortality. Also, along with the 28-day mortality, ICU-free days were also seen into the group where vitamin C was given, or also the hospital-free days were also seen more into the group where vitamin C was given as compared to the placebo, and which was supposed to be beneficial. There have been anecdotal use into China, and one afternoon on the February of 2020, where 4 patients with severe new coronavirus recovered from the Tongji hospital. High dose of vitamin C was achieved with good results, and therefore in China they suggested into these recent official government recommends the use of vitamin C into COVID, that vitamin C should be considered and initiated as soon as possible after admission. And high dose of vitamin C can not only improve the antiviral levels, but more importantly, prevent and treat the acute lung injury as well as the acute respiratory distress. This was given by the Shanghai government. And similarly into COVID pneumonia, where Cheng was the one who released the paper of large intravenous doses of vitamin C as a therapy of choice. And he took into consideration the organ failure, especially pulmonary failure, where acute respiratory distress syndrome was taken. And more importantly, the increased oxidative stress because of the rapid release of these free radicals and the cytokines, which is the hallmark in ARDS, which led to cellular injury, organ failure, and death. And therefore, large doses or high dose of large antioxidants, vitamin C, they played a very important role into the management into these patients. And this was again coming up into therapeutic nutrition in 2019. Another paper, pneumonia with ARDS, the rescue therapy was again considered with high dose of vitamin C can be considered. This was published in Lancet in 2020 on March of 20. And this again suggested that yes, potentially there could be beneficial effect. There was a reduction in there was an improvement in the PF ratios. There was also a reduction in the requirement of oxygen into those patients which required invasive mechanical ventilation. And again, the comprehensive literature or the review of the clinical presentation management of the pandemic of coronavirus in 2019. This was done by Pratham Poralkar, and this study was also published here. And they suggested that vitamin C has got physiological role, but there is evidence of supporting the protective, that high dose of vitamin C during sepsis-induced ARDS. And vitamin C reinforces and maintains the alveolar epithelial barrier and upregulates the protein channels, which I just told you, and regulating the alveolar fluid clearances. He also suggested that the plasma free cells of DNA form the neutrophil extracellular net, which is the facilitator of systemic inflammatory disease and sepsis-induced organ dysfunction. The treatment also they may be considered as 14 February randomized control trial undertaken into Zhongguan Hospital to evaluate the safety of vitamin C into viral pneumonia, and they hypothesized that vitamin C infusion can improve the prognosis of acute respiratory tract infections, and the treatment arm includes 12 grams of vitamin as an infusion for 7 days, and the primary outcome measures of ventilatory-free days. And this is estimated to be complete. The trial is still on, but up till now, the certain patients, what I just discussed, have got beneficial roles. Similarly, the safety of vitamin C into sepsis was neglected. It is essentially a non-toxic form of vitamin, and even using high dose of vitamin C thrice times intravenously was considered to be safe in cancer patients where there was a normal renal functions and also perfect G6PD activity. Yes, you have to measure the G6PD activity whenever you're supposed to start off with high dose of vitamin C. And more into renal failure, sometimes the metabolism occurs through the kidneys, and therefore you need to monitor the renal functions also. And caution is mainly applied when you're using vitamin C into those patients where G6PD deficiency, because these patients then sometimes can land up into renal failure. Clinical studies which are again ongoing is the vitamin C infusion into severe COVID-infected pneumonia. This has been registered into clinicaltrials.com, which is of the US National Library. And this study is currently being on and done by Dr. Payne, which is there. And therefore, a take-home message that vitamin C has been used into respiratory tract infections in a long period of time. It has got multiple pleiotropic effect. High dose of vitamin C during ARDS can be beneficial, can be plus minus. Again, during the ARDS, it reinforces and maintains the alveolar epithelial barrier and also regulating the alveolar fluid clearance. High dose vitamin C has been implicated in reducing the plasma cell DNA formed by the neutrophil entrapment, which is the facilitator for the systemic inflammation in sepsis-induced multiple organ failure. And other trials of high-dose vitamin C will further establish the benefits of these therapy. Therefore, it is again one of the compassionate use, one of the rescue drugs which is being tried, and this is about vitamin C. So thank you very much. So what I'll do is I'll end my screen share here, and then let's take on to the questions. I now ask Dr. Zirpe also to unmute his mic. So let's start from the So let's start from the questions here, right from the start. What we have had, we have about 21 questions which have come up. So Kapil has already just told about pool plasma for treatment. Would you like to take this question again, Kapil, in short, about pool plasma for treatment? Kapil? Hello? 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 Yes. Kapil, would you like to take this question again? Plasma, convalescent plasma in the management?
Published. Hello?
Yeah. Yes. Now I can hear you.
So out of that, 3 patients did well and 2 are on a recovery. Yes, definitely it seems to be promising. Even ICMR advised the treatment at present through trial. So please, ICMR guidelines say that if at all you want to give the convalescent plasma, you have to enroll in that trial, and then only you can use this therapy for the treatment purpose. Second thing, it should be the free of cost. You cannot charge being a trial drug at present. This is what the condition in India. So you have to go back, you have to just online registration, you have to do the registration for that trial to the ICMR, and then you can use it with the proper preparations. You have to need a good team of the blood bank, hematologists, and then you have to prepare your whole system, and then you can go ahead with the this type of thing. So don't be under wrong impression that anyone can start give this convalescent plasma to any patients without ICMR permission or through that trial registration.
Yeah. Now the second question which has been asked by Dr. Zikova is about prone ventilation and spontaneous breathing. Would you like to comment upon this? Or,
yes, there is some again the good evidences about spontaneous proning. Now, please try and understand, spontaneous proning is not a very easy act. Here you have to explain the procedure to your patient very well. You need the good cooperation from the patient, and there are steps. Just Surviving Sepsis group have published it how to do that. So there are 5 steps. First thing you did after explaining the patient, you make him prone for 30 minutes to 2 hours. It depends on the patient cooperation. It depends on the patient condition. It depends on the overall situation. Then after 30 to 2 hours, if you continue with the prone position, you have to make him in a right lateral for again 30 to 2 hours on the basis of the rest of the parameters. After that, you have to make him supine, propped up from 30 to 60 degree. Again, you can go for 30 minutes to 2 hours. After that, again, you can go to the left lateral for 30 minutes to 2 hours. And then again, you can go on repeating this cycle. So it's very simple. It's why you are doing that. It is just to do the aeration of the non-ventilated lung. So this is the process. Here, the patient cooperation, your understanding about the different positions, the staff training, and overall situation will decide the success of the spontaneous proning. So spontaneous proning is not for 10 hours. It has to be taken a call as per the situation. Thank you.
Okay. And about negative pressure, do you have any negative pressure rooms in your hospital, or what
Yes.
would you advise?
Again, we have the negative pressure rooms in our hospital, but again, try and understand we are a limited resource country. We do not have the luxury of the 15-bedded ICU with the negative pressure. What they advise, if you have a negative pressure room, you have to do the all aerosol generation procedures in a negative pressure room, like intubation, extubation, nebulization, NIV, ideally. But if you do not have the negative pressure ventilation rooms, then you can do it in a single good ventilation room also suffices. Like you have to cohort those number of the patients.
Okay. Now, there was a question on early anticoagulation role in pulmonary embolism. So here I would like to say that yes, all patients who are of COVID, definitely once they are admitted to the ICUs, those who are ventilated, definitely should be given DVT prophylaxis, and they should be kept on prophylaxis with the help of low molecular weight heparin. But those patients who worsen, and if you definitely find that there is a RA-RV dilatation with increase in the D-dimer levels, the D-dimer level should be your threshold. That if you find that increasing levels of D-dimer, then you are supposed to start early anticoagulation into these patients, because DVT as well as pulmonary embolisms have also been seen into these patients. And routinely, it would be better to monitor all these critically ill patients by means of a daily 2D echo to see for RA-RV or to see increase in the PA pressure. So this is what my thought. Any Kapil, would you like to add anything further onto this?
Yes, the literature or initial experience is that unfractionated heparin does definitely role due to its anti-inflammatory nature. One of the major concern is the anti-inflammatory nature, and this disease seems to be have a coagulopathy. There has to be there is a D dimers are very high on 5th day onwards or the after the initial phase. So anticoagulation is dual purpose. It is for anti-inflammatory as well as for the if there is a vascular microvascular involvement is there.
Okay. And are you doing CPR for these patients? And if so, what precautions are you taking for
Again,
CPR into these patients?
guidelines are quite clear. It can be the blunt question whether someone is doing CPR or someone is not doing CPR.
Or any precautions are you taking during
exactly.
CPR?
So you have to take the precautions during the CPR. Like first thing, don't rush for the CPR. Just prepare yourself, take the precautions, and then go for the CPR. Use as far as possible the full PPE during the CPR, or at least N95 mask and gloves has to be there. Second thing, don't go like a routine. You are just leaning over the patient and listening the sound and watching for the breath. That is not allowed. Look, listen, feel is not ideal during the CPR during the COVID. Third thing, for the intubation, if you are experienced one, if you know that in a first attempt might be you will succeed, then please go ahead with the intubation. Otherwise, please do not attempt the intubation during the CPR. Fourth thing, you have to keep the safe distance while doing the CPR and just minimum operators around. And you have to select your patient. If the patient is terminally ill or patient is having the already multi-organ failure, you have to take the family into the confidence and then go ahead with the CPR. So basics of the CPR regarding the airway management, the personal protective equipment while using the CPR, and avoiding unnecessary close contact with the
now for elective surgery, should we do a PCR? So let me just answer this question. See, ideally for all major elective surgeries, if it's an elective surgery, first of all, if it's a non-emergency surgery, you are supposed to defer it and try to postpone it. Yes, in case if there is if it's a surgery related to malignancy or emergency surgery, yes, definitely you are supposed to operate. But yes, as per the International Society of Surgeons, we are supposed to do a RT-PCR into those patients, and all patients who are admitted or taken up for emergency surgery should be treated and should be addressed as COVID positive patients. We are supposed to avoid doing routine gastroscopies or endoscopies during this time. Emergency procedures have to be done by taking into consideration, as is for COVID positive, wear full PPE and with minimum required staff into the operating rooms. Even normal deliveries can occur. Yes, in China, even for normal deliveries were taken, cesarean sections were also performed. In some of these patients, they also did a COVID swab into these patients. They also found that those patients, there was a paper released in NEGM, where those patients who were taken up for elective surgeries and then those swabs were positive, 25% mortality was seen, and 25% of these patients had post-operative respiratory failure and complications. This was the thing. Kapil, any additions into this on this?
Yeah, this is very debatable topic, but it's quite clear. Being a pandemic, elective procedures are not allowed. Elective surgeries are not allowed. Only emergency cases with the proper precautions. If possible, do the HRCT to pick up the early changes. If the patient is very highly suspected with the fever and cough, do the PCR and ask your surgeon to have a minimum assistant and the minimum persons inside the OT with the full PP. And the most important thing, post-operatively, I always prefer these high-risk patients with the fever and cough, or there are early changes of the HRCT, likely to be positive cases in isolation ward and ICU back, settle down there, and then they can go to the regular ward. So one need to understand that the mortality in COVID positive patients post-operative is very high. It's around about, if I'm not wrong, it is 40% in one study, and it is risk to the healthcare workers. So it's very clear, emergency operation, yes, it has to be done. It is the decision of that surgeon or that specialist to go ahead with the calling it as the emergency. Our job is to take the precaution.
Yeah. There are two questions which can be clubbed together. One is regarding as a pulmonologist seeing the patients in the OPD and for routine OPDs. Yes, routine OPDs can go on. Routine OPDs should be seen with proper social distancing, that you give appointments and see that the two patients do not sit together. There is a distance and there is a social distancing maintained in the OPD. You can see them with cap, mask, gown and with gloves. Preferably try to ask them not to get any old reports. You should see that with minimum amount of a fresh prescription should be given to them. And otherwise, I don't see any problem. Should we avoid taking measurement of BP and pulse too? Yes, we can use alcohol wash and touch the patient, but definitely you are going to wear gloves, and still you must have a proper 70% hand wash with the help of alcohol, which is very alcohol hand sanitizer 70%, which are very important. So these two questions can be taken. Any additions on this, Kapil, from your side?
No, please go ahead.
Okay, so these two we have clubbed it together. He wants to know that first of all, when you perform ventilation perfusion scan and use TPA into these patients of, you mean to say, doctor, in pulmonary embolism? Kapil, would you like to take this or?
See, if it is pulmonary embolism, then we have to do the CT perfusion scan and if it requires thrombolize, but not as a routine therapy.
Not absolutely right. And this question is there for a non-respiratory ICU patient coming from a red zone. Will you screen the patient for a COVID positive? Yes, all patients, even if they are coming from a red zone, and if they are coming with respiratory symptoms, all patients have to be admitted to the isolation ward, and a swab needs to be sent. Once the swab is negative, then they can be transferred back to the regular hospital department where it is there. Then remdesivir mechanism of action on COVID-19 and availability in India, where this question was asked by Dr. Nishalhani. Dr. Zirpe has already said that currently the NEGM paper, yes, there was a reduction in the mortality seen with remdesivir, but currently remdesivir is being used only for compassionate use. At present, it is not available in India, and in present India, it is available only through ICMR if the ICMR decides to enroll the patient into the solidarity trial, which is being done by WHO. Currently, it is remdesivir. Today also, Dr. Gangadhar into the 4 o'clock press conference, he said that it is not available in India. It is not likely to be available immediately because Ginlet company has a patent, and only if it proves beyond doubt that it is the treatment of choice, then as a pandemic act, then it will be available in India. Can N95 mask be reused? Kapil, would you like to take this question or I would answer? Kapil?
We will both will answer, but
Yeah.
see, again, I'm repeatedly saying we can't have the luxury of the N95 mask for each and every staff and every day with the everything like the countries like India, and when we don't know whether it will go for 2 months, 3 months, or more than 3 months. Yes, the answer is N95 mask you can reuse. There is a very simple way you can reuse the N95 mask, that you can label the 1, 2, 3, 4, 5. Once you the number one mask you have used for the 8 hours, just remove it in a proper technique and keep it in a dry cotton bag or any envelope. Label it day 1, then use it on the day 6. So after the 4 days, once it is dried, it is safe. At any moment during all these procedures, if it is wet or there is a moisture or it is a damage, please do not use this N95 mask. N95 mask has they are electrically charged. Their fibers are electrically charged, and that is what their integrity. Once that integrity is lost, their mechanism of the virus entry is not reliable, and those masks are not useful for prevention of the air entry. That means during the aerosol procedure, might be we will be at risk. So I will say N95 mask is use it only for the aerogeneration procedure, not as a routine, and reuse them. That's what I also started in my institute. We have given it to the high risk staff who are dealing with the COVID suspected and positive patients, and we have asked them to reuse as per this policy. Yes, Shubhal.
The next question. When would you consider elective intubation in a COVID patient? Do you have any policies for selecting a patient for intubation?
Very in your unit question and very easy answer. There is no such policies there. Again, the initially this one studies or Chinese patients were saying that don't do the early intubation. Do the early intubation and mortality. Why the Western data says delay your intubation. So I will leave it to the each and every consultants. They are learned. They know the ARDS management. They know that when to terminate the NIV trial, and it is quite evidence that if you stage the non-invasive ventilation or other options in ARDS, moderate to severe ARDS, the mortality is high. So the same principle you have to use in a COVID patients. They are not a different. Like again, the evidence is for early as well as the late intubation.
Okay. Now, as far as the use of NIV as high flow nasal oxygen, any patient who is hypoxic, those who fulfill the criteria of PF ratio, NIV and high flow nasal oxygen should be considered in those patients where we have got a PF ratio of more than 150. NIV should be considered, and definitely NIV or high flow nasal oxygen should be preferably given into areas where there is negative pressure zones are available. You need very close monitoring of the patient. In case if you find that the patient continues to be tachypneic, continues to be hypoxic, please electively early intubate the patient using the COVID protocol for intubation. Any other addition, Kapil, onto this question from Dr. Vinay Kulkarni from Nagpur?
Yeah.
How long would it
regarding the again there was initially no for aerosol generating procedures like NIV and high flow, but now the evidence is quite coming in a favor of the NIV or high flow. If possibly, if you have the negative pressure rooms, it's absolute safe to use this instrument. But in another setting also, you can use in a very selective patients who are conscious, who are cooperative, and whose PA pressure is PaO2 FI2 ratio is more than 200 to in between 300. They are the candidate, and yes, one should know when to terminate the NIV trial. That is more important rather than just putting the patients on NIV. Initially, might be you will go ahead with the high.
Yeah. Now, again, Dr. Farah wants to know how long should vitamin C be continued. See, vitamin C is really used like a drug, and it should be given for a period of 5 days to 7 days. And the cost of the injection is hardly about 150 rupees to 160 rupees, and it's quite cheap. It's not very expensive. And it should be used like a drug just for about 5 days till you get the clinical response here. Early intubation harmful in these patients? No, early intubation is definitely not harmful. You have to select, as Dr. Zirpe just enumerated, that selecting the patients for intubation, these have to be intubated. And if you think that these patients need intubation, please go ahead and intubate these patients. And early intubation is not at all harmful. It is in order to save a life. That's there. We have also discussed this question, is there any role of high frequency or NIV that has been discussed? Would you like to comment, Kapil, about the cutoff value for lymphopenia, the NL ratio?
Well, I am not getting your voice. Will you please answer?
Yeah. The question, see, the NL value, they have suggested that lymphopenia was one of the marker, and the ratio has been used as a prognosticating markers to see the worsening up of the prognosis and to prognosticate the patients of COVID. That was one of the markers which was used. And this marker was not used alone. This was used along with ferritin, the CRP values, as well as the D-dimer values. So these were the markers which were used. It is just a marker of inflammation and see the response to the treatment. If there is a double the values of CRP or the cutoff at lymphopenia goes on increasing, the ratios goes on increasing, it indicates a very bad prognosis into this. The next question is on the role of ivermectin. Ivermectin has been seen to be beneficial only in vitro. No in vivo studies have been taken, and currently it is an old anti-helminthic and anti-malarial, but currently it has not yet come. It is again being considered as a compassionate use. Any role of Favipiravir? Kapil, do you have no experience about Favipiravir?
No, I don't have any experience on that. I don't have experience on that.
Favipiravir. Yeah, so sorry. So are there chances of any false negative cases of COVID in PCR tested patients? And if there is a clinical scenario about COVID-19 infections, Kapil, can you talk about the sensitivity and the specificity of the COVID swabs?
Yeah, the way you are taking the swab is, if you are taking the oropharyngeal, your sensitivity specificity is around about 40%. If you are taking the nasopharyngeal, then sensitivity is 60 to 70%. So still your real-time PCR sensitivity depends on that type of the swab, whether experienced person is taking or whether inexperienced person is taking, and real-time PCR, it is around about 60 to 70% in the best of the hand from the nasopharyngeal.
Okay. And any experience with rectal swabs? Are you taking rectal swabs, or in which patients would you consider taking rectal swabs also?
No, the fecal-oral loop is initially they said 3%. Now it is 3 to 12%. I share that study. So honestly, I haven't done any rectal swab collection. But might be those who are with the GI symptoms, or now I came to know that there are in our city, there are most of the patients are with the diarrhea. They are coming as a COVID presentation. So okay, that might be the indication. Do you have any idea about the Shubhal?
No, I have no experience taking renal rectal swabs currently. No. Should we reduce the dose of vitamin C in renal failure? Yes, definitely you should reduce the dose by about half, like all other, depending upon the Cockcroft's GFR. We are supposed to reduce the dose also of vitamin C. Then can we opt for rampant X-ray in highly suspected area for screening purposes as far as there is a rapid? Kapil, would you like to take this question? She wants to know that, can we just rely on the X-ray because there is a shortage of the kits?
No, X-ray is not a good screening tool because it will not pick up the early changes. HRCT is advisable because it pick up the very early changes of the COVID pneumonia, and might be the lung ultrasound you can use for the triage or in your ICUs where you can pick up the early changes. But X-ray is very poor screening tool for during the COVID. It is not good unless until it is fully blown pneumonia. It will not able to pick up by the X-ray.
Now the Chinese doctor says definitely for vitamin C about 50 grams. But as I said, approximately about 10 grams of vitamin C, 10 to 12 grams of vitamin C were given as per the Shanghai protocol, or even in the Beijing hospitals. And in renal failure, yes, they had reduced the doses, but I have not read about 50 grams. It is for experimental reasons, 50 grams is okay, but up to 12 grams they have been given and been routinely used. Is there any role for digitoxin in cytokine storm? I have no experience about it. Only I've heard about the toxilumab or vitamin C or sometimes steroids into a cytokine storm. Kapil, have you heard about digitoxin into cytokine storm? No. So only these three what I have heard about it. Why isn't vitamin C included in the Indian medical protocol treatment? I haven't seen it used. See, the ICMR, unfortunately, I have no access to ICMR. Kapil is also onto the task force in Pune. So have you included it into, and have you considered to be included it into the vitamin C into the treatment protocol, Kapil, here?
As per the studies, we are just in process of preparation. I don't remember that. I will get back to you.
Okay. Now, ACE inhibitors and ARDS, should it be withdrawn? Yes, ACE inhibitors and ARDS, as per the European Hypertension Council, you need not stop it. Initially, people thought of, but now they have clearly suggested that we can safely consider continue with ACE inhibitors also. They should not be withheld. Use of steroids into mild to moderate cases to prevent cytokine storms and in ARDS. See, ARDS, yes, there have been anecdotal reports from USA, China, as well as also from India that steroids have been used into mild to moderate cases and also into severe cases of cytokine storms and also in ARDS. But the ICMR guidelines currently don't recommend it if you go as per the guidelines of the ICMR. But certain studies are have shown positive results. Certain anecdotal reports are positive. Kapil, any comments on addition into it, or are you considering to add it for all routine patients? Or are you
already I covered in my slide said that the steroid is not advisable in each and every cases. Might be initially in mild cases, we can use 1 milligram per kg to preventing them to land with the moderate to severe. But steroids are having a lot of side effect. This COVID pneumonia is a severely immunocompromised status. Please, before using the steroids, consider the all factors in your patient.
Yeah, proning has already been discussed. Even awake proning we have covered up. Even the treatment with intravenous vitamin C, the Chinese doctors say it can vary up to 20 to 50 grams. I just discussed. Yes, high dose was considered. Certain units have used 12 grams to 20 grams, but 50 grams I have not seen. Even I have discussed it with certain Chinese experts. They have considered to use about 12 grams to 20 grams only. Have you seen any ST segment elevation, Kapil, in your practice or in Rubiol? What is the incidence? AMIs?
I came across the AMIs, but unfortunately, they are not the COVID patients, but there are reports. Well, I haven't come across a single case of ST elevation in COVID pneumonia.
Okay. And can we reuse the triple layer surgical mask after washing?
No, not at all.
Not at all. Experience with convalescent plasma also we have discussed. There have only been reports of 5 patients, and now ICMR has just started the study in Mumbai, in Kerala, and also in Delhi, and they have just approved it on a compassionate basis and also for study. Any role of thiamine? Yes, as per merit studies in sepsis, along with thiamine, vitamin C, they were considered, but again, it's a plus-minus therapy again because of the anti-inflammatory properties. How many swabs have to be sent for COVID? Test oral, pharyngeal, both. Ideally, both the swabs have to be sent, the oral as well as the nasopharyngeal swabs for oral testing.
Shubhal, I think we have now
completed almost all the questions. We have completed all the questions. I hand over now to Arun. Arun, we have completed all the questions. Arun.
Sir, I'm here, sir.
Arun, we have completed all the questions, so I would like you to take and end this meeting. On behalf of Dr. Zirpe and myself, I thank for inviting both of us to give this presentation today on behalf of Converge Biotech. So Arun, please take over.
Thank you, Shubhal, and thank you, Arun, for inviting me.
Sir, I would like to take this opportunity to thank Dr. Kapil Zirpe sir and Dr. Shubhal Dixit for giving their valuable consent to participate. Thank you so much for your presentation, sir. I'm sure everyone gained a lot of insight into COVID-19 management. My sincere thanks to all the participants for joining us tonight. Looking forward to meet you again with another interesting topic. Stay safe and together let's fight COVID 2019. Thank you, sir.